Greetings from Fourrts. We welcome all doctors to this live webinar. And this webinar is slightly different, as we already mentioned, because which is going to be an interesting dialogue between two renowned doctors. And we are honored to have two esteemed doctors who are going to talk and discuss about HELLP syndrome and eclampsia. We thank Dr. Usha Viswanath and Dr. Jaya Vijayaragavan for giving an opportunity for conducting this live webinar. And Fourrts is in the pharma industry for the past 40 years, following the motto of innovating for good health. At present, we are exporting our products to over 50 countries around the world, and we have a wide range of products in gynecology and IVF segments. Our products cater from prenatal care to UTI therapy, and our brands are Prenatal, Argin, KMAC, and NACFIL4. We welcome Dr. Usha Viswanath, Madam, who needs no introduction, and Madam is a professor and head of obstetrics and gynecology in Sri Ramachandra Institute of Higher Education and Research, and Madam is the sole author of textbook of obstetrics for UG and PGs by Elsevier, and she is also the chairperson for Hospital Quality Assurance Division at Sri Ramachandra Hospital, and Madam has designed mobile app Suraksh for intrapartum monitoring of patients, and she has also been awarded Diploma in Hospital Administration by National Institute of Health and Family Welfare, New Delhi. And we also welcome Dr. Jaya Vijayaragavan, Madam. She is also very renowned and an eminent doctor, and she is the professor and senior consultant in Sri Ramachandra Institute of Higher Education and Research. And Madam has chaired session, and she has delivered guest lectures in various conferences. And Madam was also the former HOD of the department. And Madam has delivered guest lectures in various state, zonal, and national level conferences. And she has been the guide for several PhD and research work. And Madam has done major gynec obstetric emergency, oncology, and laparoscopy work. And Madam is also teaching and training of undergraduates and postgraduates. Thank you for both the madam for accepting our invitation, and over to respectable doctors for further proceedings. Thank you very much, ma'am. Yes, ma'am.
Thank you, Usha, for that introduction. And we welcome you all for yet another episode on HELLP syndrome and eclampsia, a dialogue between Professor Jaya Vijayaragavan and myself. Okay, we will start with a case scenario. So here this is a 26-year-old primea gravida who is at 31 weeks of gestation. She has history of headache for about 2 hours. She has a blood pressure of 140 over 90 millimeters of mercury, and she started on magnesium sulfate. These are the investigations. Her hemoglobin is 13.4, her platelets are 55,000, and her OT is 640, PT is 958, LDH of 902, serum bilirubin of 3.14 milligrams per deciliter, and a urine albumin of 3+. Now, my question to Madam is this sufficient to establish the diagnosis of HELLP, or do we need additional investigations?
Madam Jaya, madam's mic is in mute.
Yeah. Good evening, everyone. Yeah, just before we go on to the discussion of the case, we all know that HELLP syndrome definitely requires help, and it's always an obstetrician's nightmare. And patient can hear it was obvious that the patient had symptoms of preeclampsia and had imminent signs. But you may find a patient who just presents with a flu-like symptoms, and when you do her investigations, you'll find a flaudid HELLP staring at you. And patient can just present with just proteinuria and edema with no hypertension at all. So it can have a varied picture. So you should have a high degree of suspicion when a patient comes unwell to the hospital. And having said that, when we go on to the investigations, which Dr. Usha had already projected, She had a hemoglobin of 13.4, which points towards some amount of hemoconcentration. The diagnosis here is not difficult because she had a platelet count which was 55,000. Generally, you will have a low hemoglobin because of hemolysis, but here probably because of dehydration or whatever, she has a high hemoglobin which is contradictory to HELLP syndrome. But platelets are definitely less, which falls into the Mississippi type 2 classification. We don't go into much into the classification. We just see into the severity. She has a high SGOT, SGPT, which again points towards altered liver enzymes. And we have a high LDH, which again points towards hemolysis. The bilirubin is raised probably because of hemolysis. And she has a urine of 3+ albumin, which points towards preeclampsia. So in this patient, the diagnosis of HELLP is definitely evident. We don't need to do investigations just to diagnose HELLP. But definitely we know that HELLP syndrome is associated, particularly the class 1 HELLP syndrome, is associated with DIC in 20% of the cases, abruption in 16% of cases, acute renal failure in 7%, and pulmonary edema in 3 to 10%. So we need to know the severity of this HELLP syndrome, and that's why we would need to know other additional investigations.
Thank you, ma'am. What is the role of manual
investigations?
Yes, ma'am. Please go ahead with additional investigations.
So therefore, we would definitely require additional investigations in this case, like coagulation factors, PT, PTT, INR. We would like to know the renal function test, and we would like to probably do a peripheral smear to tell us about evidence of hemolysis, but hemolysis is evident here. So we need not do a peripheral smear, but that would help us in times when we are unsure whether there is hemolysis going on. There are tests like low haptoglobin, which reveal the evidence of hemolysis, but that is also not usually routinely done here. Having said that, we also need to do an ultrasound, not for diagnosing the hematoma, which is very, very rare, but definitely to know the fetal status, because IUGR, Doppler changes are very well known. IUGR occurs in almost 1/3 of the cases of HELLP syndrome, and a perinatal death is as high as 7.4% to 34% in patients with HELLP syndrome. So therefore, we would need additional investigations to know the severity of the HELLP syndrome and what we are going to face in future.
Thank you, ma'am. Do we need to do a manual platelet count once we get a report from the lab? When do we want to do a manual platelet count?
Clumping of platelets is very well known in many of these patients who present with low platelets. So in our hospital, many times even the anesthetist asks for a manual platelet count, where when you have an automated platelet counter, the entire clump is measured as one platelet. So therefore, it gives a fictitious wrong reading that the patient has very low platelets. But if we do a manual platelet count, we would be able to get a better understanding. Many times when you have an automatic analyzer, it shows as 50,000. But when we count on a manual count, it is as high as 85,000, and we breathe a sigh of relief when we get a count of 81,000. Nowadays, we have special machines called flow cytometer, which does this job for us instead of a manual platelet count. But not all labs and not all universities or not all colleges will have this flow cytometry to do a platelet count and get the correct reading. So we need to do a platelet count whenever it demands. And in our hospital, the anesthetists do ask for it. When they come across there is no coagulation disorder, but the platelet counts are low, then many times they do ask for a manual platelet count.
So when there is a mismatch between the clinical presentation and the count of platelets, we may have to do a manual platelet count. So when you have a patient with HELLP syndrome, very often we are tempted, can we prolong pregnancy? She's only 31 weeks. The neonatologists feel we need to wait a little longer. So what is the role of conservative management in HELLP syndrome?
Yeah, since this patient is 31 weeks only, we would definitely be tempted to pull on the pregnancy for some more time. But having said that, one should not be bent on prolonging the pregnancy, particularly in class 3 HELLPs, where the platelet counts are very low. It may not be feasible for us to continue the pregnancy. In patients who are more than 34 weeks, definitely we should not be prolonging the pregnancy, because we all know that the mother's health is severely jeopardized. And these are specific contraindication, more than 34 weeks and very low platelet count associated with coagulation disorders, abruption, and all these are very, very serious things where the mother could be pushed into the jaws of death. So in these conditions, we would definitely not like to give a conservative management. In other patients where she is less than 34 weeks, then we may be tempted to prolong the pregnancy if all the maternal and fetal parameters are acceptable. And in these cases, we would definitely go on to a conservative management, but we would like to repeat platelet count, coagulation profile every 4 to 6 hours. So a patient presenting as class 1 HELP may suddenly turn to class 3 HELPs, in which case you may have to hurry and deliver her. So with vigil monitoring in patients who are less than 34 weeks of gestation and who do not have any coagulation disorder, do not have any signs of abruption, no signs of maternal angiopathy, there may be a small role for conservative management. Of course, your eyes and ears should all be open when you're giving a conservative management, because it could push the patient from a class 3 HELP to a class 1 HELP at any point of time.
Thank you, ma'am. I hope you all listened to Madam saying that there is a small role for conservative management. And please put that word small, big thing in your heads, because practically it is not conservative management. As far as HELP syndrome is concerned, we need to terminate pregnancy. Let the prematurity not tempt us to continue. What is the role of steroids? We hear people giving high dose steroids, IV steroids for low platelets. What is the role of steroids in HELP syndrome?
IV steroid definitely has some benefits. They increase the platelet count, they improve the liver function, they improve the urine output. But however, there is no improvement in the overall stay or the overall course of the disease. It does not alter the course of disease, although it gives us a false impression that it improves certain things. And there have been many studies which have small studies which have showed improvement. But the Cochrane database, which had looked into almost 11 studies with 550 patients, have found no benefit, and therefore it is not really used. However, having said that, for the benefit of postgraduates, I would like to say in these conditions, IV dexamethasone is preferred over over the betamethasone, and the dose is very, very high. If you see, it is almost 10 to 20 milligram given every 6 hours, depending on what your platelet count is. And such high doses may push the patient into hypertensive encephalopathy. So whenever a drug which can just gives us a marginal benefit, and not to say that it alters the course of the disease, I don't think we should be using them. And we have enough evidence from big bodies, RCOG, ACOG, Cochrane, to say that it does not have much benefit.
So we all get to agree that steroids, especially high-dose steroids intravenously given, has no role as far as HELP syndrome is concerned. So the next question comes, we want to terminate pregnancy in her. How are we going to terminate? Do we need to do a cesarean section only, or is there a role that we can induce labor in these patients?
Our patient happens to be 31 weeker. And we all know that if we have to terminate in the pregnancy in this patient, probably because of low platelet or she's going in for coagulopathy, we need to probably do a cesarean section, because her Bishop score is very, very low. It's bound to be very, very low. And this baby probably could be an IUGR also, which will not tolerate the prolonged induction which these patients need. So most of the time when the pregnancy is less than 32 weeks, most of us would decide for a cesarean section unless the patient has come well in labor and is due to deliver in a short time. More than 34 weeks, if there is no coagulation disorder, then the cervix is quite favorable. We could probably attempt a vaginal delivery by inducing the patient, and both prostaglandin E2 gel and misoprostol are both acceptable as a mode of induction.
Thank you, ma'am. So we need to understand that whenever we have situations like an eclampsia, abruption, HELP syndrome, severe preeclampsia, or any of these situations where we need to terminate for maternal and possibly for fetal reasons, the maximum time limit that we can probably stretch is not anything beyond 6 hours. So it's always that magical 6 hours, because beyond which we know that complications are going to increase. So if we are planning for a cesarean section in this patient, now let's wear the hat of anesthetist and see what kind of anesthesia is this patient going to be subjected to.
Just as we are scared about these low platelets, anesthetists are doubly scared. And they would not touch a patient with such low counts, and definitely not for a regional anesthesia. In case as an emergency, we have to operate on a patient with abruption with such a low platelets, they would definitely go in for a general anesthesia. Now, when are the conditions where they would go in for a regional anesthesia is when the patient platelet count is more than 75,000 to 1 lakh. Our anesthetists prefer the platelet count to be at least 1 lakh, provided if they want to give a regional anesthesia. And most of them would not go in for a epidural analgesia also in these cases for labor, for pain relief in labor. So the minimum platelet count which they require to give a local anesthesia or a regional anesthesia for cesarean section would be at least 1 lakh in our hospital settings.
So the guideline is a minimum count of 1 lakh to either give a regional anesthesia or to give epidural analgesia in patients with.
And one more point from our side, when we are also performing LSCS, we need to take certain precautions, and that is we will leave the bladder flap open, which most of us do now, and we must put a subcutaneous drain. In our setting, we also put a peritoneal drain because this patient could have an ongoing drop in the platelets even postnatally. So as a precautionary measure, we would not close the bladder flap, leave an intraperitoneal drain as well as a subcutaneous drain to know whether she is bleeding from any point of time.
Okay, ma'am. Now, blood and blood products. I know anesthetist and everybody is going to be at the back of our heads that we need to get them ready. So what are the blood products required for this condition? And what is the alert role for massive transfusion protocol in these patients?
As luck would have it, most of the time we escape from doing calling a massive transfusion protocol. This is really indicated when the patient comes from outside, bleeding, probably a PPH following a HELLP syndrome or an abruption or gone in for DIC, or in AFLP where there is a massive obstetric hemorrhage and she is being referred from outside. In those conditions, we have to alert the massive transfusion protocol. Of course, we would be getting some few details from the other obstetrician who is referring us. So these are the very few times when we have to alert the massive transfusion protocol. And most of our experience in massive transfusion protocol comes from the trauma patients wherein they give O negative uncross-matched blood in the ratio of 1:1:1. One PBRC, platelet, packed vessels, one platelet and one FFP. So that is the ratio in which they would allocate. But fortunately, we have not had any opportunity to alarm the massive transfusion protocol in our hospital for HELLP syndrome. Having said that, we do need to have blood products ready in the while managing a HELLP syndrome patient, and we require all these products, all the FFPs, platelets, as well as red blood cells ready when we are managing a HELLP syndrome patient. And we generally keep 4 PBRC ready and 4 platelets and a couple of platelets. Depending on the platelet count, we would be reserving the platelets. Our anesthetists prefer single donor platelet, at least 1 or 2 packs, which will increase the platelet count by 25 to 30% per pack. And a single donor the conventional platelet will only increase by 10,000. So we would require more number of platelets if you are using the normal platelets. But if you are using a single donor platelet, we would require just 1 or 2 packs ready.
So it depends on the competence of the blood bank, whether they can provide us SDP or RDPs, random donor platelets or single donor platelets. SDPs are always preferable, like Madam said. A single unit itself will escalate the number of platelets. And there is no role for prophylactic platelet transfusion unless the count goes less than 20,000, because the lifespan of platelets is very short. It's just about 3 days. So that is something we need to understand. So we shouldn't get enthusiastic about just unnecessarily giving prophylactic platelet transfusion. Now, after transfusing 1 unit of SDP, single donor platelet, and on flow, patient is being taken up for emergency cesarean section. She delivered a girl baby weighing about 2 kgs and being shifted to the neonatal ICU. Incidentally, she also has atonic PPH, which has been managed medically. So what are the investigations we are going to be doing for her postnatally, and how often are we going to repeat these investigations?
Yeah, having delivered, of course, we all breathe a sigh of relief once the patient has delivered. We have managed the HELP syndrome, but it is not so. HELP syndrome can even start postnatally, or it may continue postnatally. So for 24 to 48 hours, we have to be vigilant. We have to be vigilant, and we must continue to do the hemoglobin estimation or a complete blood count with platelets. We must continue to do the LFT, and we must do the renal function test, because some of them can go into renal failure or pulmonary edema even postnatally. So we must keep a monitor on all this. Depending on how the patient behaves, you could probably increase the time of your investigations. But initially, for the first 24 to 48 hours, we do repeat all these parameters every 6th hourly. The coagulation profile may be made less frequently if the platelet count starts rising. So it all depends on, definitely we do complete blood count, platelets, and the liver function test and the renal function test every 6 hours till the patient stabilizes. Coagulation profile we may do depending upon how bad the coagulation profile was it antenatally and how the platelets are behaving at this point of time.
Okay, so we need to remember that the first 48 hours is the most crucial time when the patient can deteriorate, and so that's a very important time to monitor her very closely. So if her serum creatinine increases to 1.8 milligram per deciliter, what are all the possibilities in mind?
Can I have the next slide, please? Yeah, the creatinine count could go up even in a case of HELP syndrome. But having said that, there are other variants. Some people call it variants, some people call it an extension of HELP syndrome. We must think of other possibilities in mind. Why we should know about the other possibilities is that you may be dealing with a hemolytic. These are very, very rare, but they can occur postnatally. But then whenever the patient is not responding to your routine management, then you must think of HUS and TTP in mind. And AFLP, of course, has got other characteristics which will warn us, like they may have leukocytosis, they may have hypoglycemia, which could have warned us when we started itself, and they behave really, really badly, and they come with severe coagulation disorders. So that is one thing you need to know about AFLP. If the patient looks very sick, she presents with DIC, and she presents with hypoglycemia or leukocytosis, then AFLP is an answer, and definitely it behaves worse than our HELP syndrome. With regard to HUS and TTP, TTP will definitely have more neurological problems. We will have more neurological problems, and HU will have more renal problems. Having said that, why do we not need to know the differences? That if the patient does not respond to your treatment, then probably we should get in the neurologist, we should get in the nephrologist, and we may probably need to get in the gastroenterologist to see whether we are dealing with any of these variants. And in case of HUs and TTP, plasmapheresis will help if your routine management does not help. This patient had a raising creatinine postnatally, so it could be just a HELP syndrome, and by continuing to monitor all the parameters, we may probably tide over the crisis. But if we are not able to tide over the crisis, we must think of other alternatives.
Okay, now the next question is, what is the role of TEC in this patient?
Yeah, TEC is something which has come in very, very recently, and we have been using it in our hospital for a past couple of years. Initially, I was also not very familiar with that. But whenever we are transfusing blood and blood products, you may want to know when we should stop these blood products, because the patient was in DIC and you have started platelets, you have started fibrinogen, you have started cryoprecipitate, you have given a blood transfusion, but you are not really able to understand when you should stop and what you should do. So in this, tech becomes very useful. It is a point of care machine. It is a point of care machine which is available in many centers in the near the patient serving area, also in the ICU setting. So in these cases, it will tell us what we should give, how much we should give, and when we should stop. Can I have the next picture? Picture of TEG. Yeah, so this is one thing which tells us, it has the R time which tells us whether the blood is clotting or not, when the clot is forming. It has a K time which tells us the clot reaches a fixed time, and the alpha angle which is there, or the amplitude, which tells us the strength of the clot. And last of all, you will even know the L/30 time, which tells us whether there is fibrinolysis happening. So depending on that, it will give us an answer. And if it is the R time is prolonged, it will say give coagulation factors. If the K time is prolonged, it will say give fibrinogen. And if the lysis time is this thing, it will say give us fibrinolysis. And you will be surprised to know that we had a patient where we kept on giving blood products. And then when we looked into the tech, it says give fibrinolysis, and we started giving her tranexamic acid. So it is very helpful in times as to when to stop our the blood products. So it is very useful. Of course, there are other things which are available. Next two slides. Next two slides. Yeah, we have this rotum, which is a similar form of tech. Only thing, the R time and the T time and all that is slightly variant, but ultimately it tells us what we have to give and what we should not be giving. So it is just an extension of that. Only thing, the way the machine works is different. Next slide. So generally it tells us about the clot firmness. The initial part, it will tell us what products to give. Then it will tell us how firm the clot is, and the last part of it will tell us whether we need to give fibrinolytic agents. So it is automated, and you can get the answers on the graph itself.
Okay, ma'am. What is the role of prophylactic steroids in this patient?
As I told you, if the patient is less than 34 weeks pregnancy, definitely there is a role of steroids and magnesium sulfate. Having said that, in HELLP syndrome, the patient's condition may deteriorate so fast, but if there is a jeopardizing maternal or fetal condition, we need not even wait for the steroids or maxils. Otherwise, they definitely have a role for improving lung maturity and for reducing the cerebral palsy or a neuroprotective effect of magnesium sulfate.
Okay. So what is the postnatal follow-up of this patient with HELLP, and what is the counseling in case she wants to conceive again?
We have to understand that we can't breathe a sigh of relief, as I already said, that we need to continue to monitor her, and some of them may take 48 hours to settle, some of them may take even a week to settle. So till she settles, we should continue to monitor the patient. Of course, most of them would settle down within 48 hours, but there are people who can have a prolonged way of settling. Postnatally, of course, the baby has to be followed up for preterm, prematurity, for respiratory distress and IUGR. And babies also can have a low platelet count, which needs to be monitored. With regard to her counseling, as I told you, in the postnatal, we should continue to do the hemoglobin, platelet, coagulation profile, LFT and RFT. And hemoglobin and platelet should be repeated every 6 hours. LFT, RFT, if it's not too bad, can be repeated every 24 hours, and coagulation profile depending upon the derangement. With regard to her counseling, we should tell her that she has a future chance of developing preeclampsia in the next pregnancy, IUGR, preterm delivery, and also the risk of, however, as a solace to us, the risk of abruption and repeat HELLP syndrome is just 2 to 3%, whereas the risk of developing a preeclampsia in the next pregnancy is as high as 19%. And this patient should be followed up with an APLA screen definitely before she embarks on the next pregnancy, so that we may need to start her on low dose aspirin and heparin if the APLA screen is positive. Thrombophilia screen, some do it, but it is not routinely recommended as a postpartum follow-up of HELLP syndrome for the next pregnancy. Having said that, if she becomes pregnant, we should start her on we should start her on Ecosprin 150 milligram before 16 weeks of gestation, and we must put her on the first trimester screening of preeclampsia, which I talked to you all last time.
Thank you, ma'am. So we heard a lot about how HELP syndrome needs to be managed, how we need to diagnose, how we need to terminate pregnancy, what are the various complications that can come because of HELP syndrome. And the first 48 hours are very crucial in follow-up of these patients because the investigations and the condition can deteriorate. And there is a role of steroid and magnesium sulfate for neuroprotection and counseling for future pregnancy as far as this patient is concerned. Now we move on to the next case scenario.
Yeah, now it's my time to ask questions. So I'll do it very gladly. We have a 25-year-old primigravida patient who is booked outside, comes to the emergency with 2 episodes of convulsions and one more on the way to the hospital. She gives a history of high blood pressure on treatment from 30 weeks of gestation, and soon after arrival to the hospital, she throws another tonic and clonic convulsions, and her blood pressure at that point of time is 150/100. My question to you is, the diagnosis clear-cut. I don't think there is any doubt in the diagnosis. What are the principles of management of this patient, Usha?
I think we need to first remember that before we close down HELP syndrome, that HELP syndrome can have blood pressure that is not really too high. It can just border around 140, 90, and they can still throw convulsions and they can have eclampsia. So whenever you have patients having a new onset grand mal kind of seizure in pregnancy, the first thing that comes to our mind is to think of eclampsia. So there are 4 principles that we need to think of whenever we manage a patient with eclampsia. The first is obviously airway breathing and circulation. The patient shouldn't be lying flat and supine. There is a possibility there can be a falling back of the tongue, there can be obstructive apnea, there can be secretions which can go into her lungs. So the first thing is make sure that her head is turned to the side and make a clear airway, clear secretions if there are any. The breathing has to get better, so obviously you're going to strap her onto an oxygen mask, and not less than 4 to 6 liters per minute of oxygen has to be administered. Circulation is C, which is very important, so we need to make sure that there are at least 2 IV needles, that is possibly patent, so that we can take care of both all the 3: airway, breathing and circulation. So that becomes the first principle. The second is handling her hypertension. So we definitely need to give her antihypertensives, and we discussed at length last time. We give intravenous labetalol. We need to make sure that, we need to remember that very high blood pressure is going to give rise to hypoperfusion and give rise to eclampsia, secondary to which you can also have cerebral hemorrhage. So we need to get the blood pressure under control. So antihypertensive therapy becomes the second principle. And then the third, obviously, is the control of convulsions. Now, convulsions need to be controlled. We are now going to be talking of the regime. So, magnesium sulfate is the only drug that is currently being used for control of convulsions. And the last most important principle is the obstetric management. There is no role for conservative management at all. There is no way you can continue pregnancy in an eclampsia. She may just be 28 weeks, she may be 26 weeks, she may be 30 weeks, doesn't matter. If she has eclampsia, please remember the most important 4th principle is you have to terminate pregnancy in this patient. We sometimes are forced to overlook the well-being of the baby for the sake of the mother.
Madam, mic is in mute, ma'am.
Thank you, Dr. Usha, for highlighting the 4 principles of management of a case of eclampsia, which we time and again reiterate to you all in the form of drills and which should be kept in our mind whenever we are managing an eclampsia patient. And all of us must know to manage a case of eclampsia. Now, having said that, the most important point is the magnesium sulfate regimen. And what kind of regimen would you administer in your patient in this situation?
This is Zuspan's regime, that it's accepted modality of treatment for eclampsia. I know a lot of practitioners, especially in nursing homes or smaller centers, are really very wary of using Zuspan's regime. It is pretty much safe rather than giving intramuscular, because we know it is cumbersome and it gives a lot of pain to the patient to have that heavy load of magnesium sulfate into the buttocks of the patient. So now Zuspan's regime, I want to really simplify. Now 1 ampule has 50% of magnesium sulfate, which has 2 ml. Now this 2 ml is supposed to have 1 gram. So it has 2 ml is equal to 1 gram of 50% magnesium sulfate. Now this is the loading dose. We know we are going to give 4 grams of loading dose, which is 20%. So if we take 4 ampules, obviously each of them having 1 gram, it gives 4 grams, which is 8 ml of 50% of magnesium sulfate. Now we need to convert this 50% concentration into 20%. So this 8 ml that is there in the 4 ampules, we add 12 ml of distilled water. So it converts this into a 20% with 4 gram of magnesium sulfate, which is given as a bolus as a slow IV 15 to 20 minutes. Believe me, just give this confidently and don't get apprehensive that this can give rise to problems. You're after all giving intramuscular. So in that way, intravenous is not going to add on to any kind of side effects or complications. Then you have a maintenance dose. Maintenance dose, we know that we have to give 1 gram per hour, which is about 50 ml per hour, 12 drops per minute. You can titrate it depending on the need to a maximum of 2 grams. So I repeat, you give a loading dose, 4 grams of 20% magnesium sulfate as a slow IV bolus, and then we give an infusion of 1 gram per hour, which is 50 ml per hour, which is the maintenance dose. So this is something that both of us want to really reiterate. Please don't get apprehensive about starting Zuspan's regime, and I hope at the end of this webinar, at least a handful of you would like to start and would really start Zuspan's regime in case you are still with Pritchard's.
Yes. So Dr. Usha has highlighted on the Zuspan's regimen, which most of us now use in our centers. Now, there are certain people who will be saying that patient has no renal output. In renal failure, would you still give the loading dose, Usha?
You can still give the loading dose. It depends upon the amount of output that the patient has, and it also depends on the renal function tests. And you can still go ahead and titrate the dose of magnesium sulfate and still administer, unless otherwise patient has very severely compensated renal function.
Yes, so the point to highlight is here, the loading dose can be given irrespective of the urine output. Only the maintenance dose or the other doses we need to curtail depending upon her renal functions. Now, there are some people who would say that the patient is very thin built. Our Asian women are not as well built as the Western population. So we can give 3 grams dose or 2 grams dose. Do you agree upon that, Usha?
I don't think so. And anyway, our women are no less heavier than our counterparts at the West. So I think there is no role for underplaying the dose of loading dose. We need to give the 4 grams as a loading dose.
And coming to the Pritchard's regimen, do you think that it should be thrown out of the window, or does it have some role in practice?
I think if there is a transition phase where people are moving from Pritchard's to Zuspan's, it's going to take a little time for them to get convinced. And Pritchard's it doesn't mean that we can move away, but Zuspans has been proved to be a superior method. So until they feel comfortable, I think slowly it is easier to switch to Zuspans.
The only other area where I think intramuscular is accepted is when the person is not qualified to give the intravenous regimen, which happens when there's only an ANM ruling that. But having said that, you have to be very careful that these patients can have coagulation disorders. And once you give an intramuscular regimen, they even can develop hematomas. So that point has to be kept in mind. But however, when there is nothing, it is always better to do something than nothing in a patient who is fitting. So you can give the intramuscular regimen where the person is not qualified to give an intravenous regimen. Now, having said that, is there any role for vaginal delivery in the patients with eclampsia?
I think to continue with the previous thing, it's preferable to shift patients of eclampsia to a higher center where there are more competent people to be managing, because there can be plenty of complications while managing these cases. Role of vaginal delivery, very commonly answered by postgraduates. They think that if there is eclampsia, they have to have only a cesarean section. That's not so. They can have a vaginal delivery provided you feel that laboring through normal delivery is imminent in the next 4 to 6 hours, so or even 6 to 8 hours, and there is no maternal or fetal compromise. We can still, the best way would be to have a favorable Bishop's force so that we can induce them with an artificial rupture of membranes, rather than have an unfavorable cervix, in which case we may have to tilt our decision towards a cesarean section. So there is a role for vaginal delivery if there is a favorable Bishop's force, and if we can probably induce labor with an artificial rupture of membrane and augment labor and deliver her vaginally within a time span of a maximum of 6 to 8 hours.
Yes, one should not jump to cesarean section, and particularly you must stabilize the patient also before you even go for a plan the delivery. And there is a role for vaginal delivery if the conditions, maternal and fetal conditions, are favorable. What sort of education is required in such patients, Usha?
I know the patient is in no state of mind for an education. It's mainly the family that requires huge education, because they are very apprehensive that somebody has thrown convulsions, and convulsions always give us alerts, because we have not, and they would say that she is somebody who has never had a fits in her life, and this is the first time that she's throwing convulsions. So we need to tell them one thing, that whatever changes are happening with in terms of eclampsia are all reversible. That's the most important thing that we need to tell them. And of course, we need to highlight that these are the various complications that may happen, starting from abruption or DIC or any cerebral hemorrhage or various other complications that are possibly likely to have. And depending on the patient and her condition, we need to fine tune our education so that we don't frighten them, but at least we are able to tell them that these are the possibilities. So the family needs to be reassured, and at the same time they have to be told that these are the possible complications this patient can have. Most importantly, these are all reversible, because preeclampsia, we know it's a disease of abnormal placentation, and the moment the culprit is out, things are going to reverse in almost all patients.
There are times when you have patients coming before 34 weeks, and our neonatologist said, can't you not pull on for some more time? So in those situations, would you like to please the neonatologist by giving conservative management for at least some time for the steroids and the Maxwell and the other things to act?
Conservative management for basically means you are wanting to prolong the pregnancy till you reach the magical number of 37 weeks. But if it is only a period of tiding over for the benefit of steroids, or for that very short 24 to 48 hours, it still depends on the maternal conditions, where we have to be extremely careful while we are moving them, especially the gestational age less than 34 weeks. The bottom line of managing any patient with eclampsia is to terminate pregnancy at the earliest, at the same time not compromising the maturity of the fetus. So it is a totally precarious balance that we need to keeping both maternal and the fetal well-being in mind. And there is definitely no role in prolonging pregnancy, but for the benefit of steroids or for the benefit of drugs that will help the fetus, it has to be individualized, and it is only that particular condition where you have to have a discussion with the neonatologist. So the bottom line that we want everybody to understand is eclampsia means termination of pregnancy. There is no role for prolongation of pregnancy.
Yes, it definitely depends on the maternal and fetal parameters for us to decide. And in these conditions, the more the maternal parameters are the most deciding factor. If there is a jeopardy of any of these, you should not hesitate to go ahead and deliver the baby. Now we are talking a lot of this neuroimaging, which plays a role, and every second patient is being subject to a MRI or MRV or MRA or whatever they say. Is it really necessary to do so much of imaging in these patients of eclampsia?
Ma'am, I think when they have antepartum eclampsia, the role of imaging is very minuscule because we know that patient has eclampsia and then we treat her with Maxel, try to deliver her at the earliest. But if you encounter a case where patient is throwing multiple convulsions and they are having recurrent episodes, then we probably will have to think of a neuroimaging. Or if patient is not returning to her consciousness and then she's remaining in a state of coma, then or her GCS is getting low, then definitely we will have to think of doing a neuroimaging. Neuroimaging has a greater role as far as postpartum eclampsia is concerned, because we normally know that the first 48 hours are the highest risk period for woman throwing convulsions, beyond which we feel that she's not going to be having eclampsia. So postpartum period is a role where definitely we may need to do a neuroimaging. And there have been plenty of studies to say whether it is an MRI or it is a CT. Now, the comparative studies have shown that both of them are absolutely similar as far as the results are concerned. But there is an edge of MRI for various reasons, of logistical, non-invasive reasons. We choose MRI. And of course, we have to think in terms of conditions like a press, the posterior reversible encephalopathy syndrome, which very often sometimes because of that vague presentation we may miss. And MRI in the case of eclampsia, it may just show a hyperdense lesions. So it may not show anything much if it is just eclampsia, but if it is press, there may be a few features which may be suggestive. So definitely neuroimaging is done in antepartum eclampsia if there is recurrent seizures or if there is no return to consciousness. And in postpartum eclampsia, definitely there is a role for neuroimaging.
Yeah, having said that, there's also a question in the question box. Let us complete that also. Is there any role for injection Levipil?
Levetiracetam has a role, especially in postpartum imaging, and we know that it is a safe drug that can be given even during pregnancy. So in case we encounter a patient with postpartum eclampsia where the neuroimaging is showing certain changes, there may be a role in consultation with the neurophysician.
Yeah, so we have probably answered most of the questions of eclampsia, and I think the bottom line is all of us must be trained to manage a case of eclampsia. We should know the 4 principles of management like airway, breathing, circulation, the management of hypertension, the management of convulsions, and last of all, the obstetric management, which was very well highlighted. There is no role for conservative management unless under very special circumstances where you want to where you want to give steroids and Maxels, you may probably give that 48 hours time, but under strict vigil monitoring of both the mother and the baby, and definitely not when a patient comes less than 24 weeks with eclampsia. So having said that, we must all know about the Zuspans regimen, which is very convenient and very easy for the patient, and all of us must change from Pritchard to Zuspans regimen. Thank you, Usha, for highlighting the postgraduates on most of the aspects of eclampsia. If there are any questions, we will take it.
Thank you, ma'am. We are now open to questions.
There is one question in the chat box which says, patient had double valve replacement and gestational hypertension with HELLP, and LSCS was done. What is your opinion on anticoagulant therapy versus HELLP? HELP, if it was associated with coagulopathy, then obviously she would have to be treated with FFPs. And till the coagulation settles, then we need to continue the blood and blood products till the coagulation settles. After that, we treat her like any other patient who has a double valve replacement. We start her on low molecular weight heparin and then start her on the vitamin K antagonist.
There is a question which says, what's the difference between Zuspan and Pritchard's regime? Zuspan is an intravenous method of administration of magnesium sulfate, and Pritchard's is given intramuscular.
Sibai, when is Sibai? When is Sibai regimen advocated? Maxel for prophylactic preeclampsia. Eclampsia, prophylaxis, severe preeclampsia. Sibai regimen enakku theriyala. I don't know. Sibai.
The two commonly used regimens are Zuspan's and Pritchard's regime. We don't use the Sibai's regime, and the use of diazepam and various other drugs are no longer in the guidelines. In a patient with history of late onset preeclampsia and previous pregnancy a year ago, what should be the frequency of ultrasound and how should she be monitored? I don't understand why ultrasound frequency. She's had eclampsia a year ago in the previous pregnancy. I don't see any role for ultrasound. Why should she be monitored? We just need to make sure that her blood pressure is monitored very carefully, because there is a possibility that her blood pressure may increase during this pregnancy, and the chance of having a second time seizure in this pregnancy is increased because of her previous history.
Magnesium sulfate is definitely given for as a prophylaxis when patient comes. Last time we did mention, no, whenever the patient comes with severe imminent signs, severe high blood pressure and preeclampsia with severe features, then definitely there is a role of magnesium sulfate, even if the patient has not thrown a fit.
Is Zuspan regime superior to Pritchard? Definitely, there's been plenty of studies to show that Zuspan's regime has made plenty of benefits, and it is more comfortable to the patient. So definitely Zuspan is the accepted guideline. Ma'am, would you like to answer this? Previous history of fetal demise with severe preeclampsia, now in the second pregnancy around 8 weeks. What should be done now to prevent such mishap?
Yeah, we need to know whether she has been screened for APLA. If she has been screened for APLA, you can start her on low-dose aspirin 150 milligram as said in the ASPRI trial. She will come under the high gestosis score of 3, and therefore we can start her on aspirin along with calcium. And in case of low molecular weight heparin, we may have to do it unless this thing shows APLA positive. Then we will not give, we will give low molecular weight heparin. And all this should be started, aspirin can be started as soon as we know that it's an intrauterine gestation, and preferably to start before 16 weeks of gestation, by which time the trophoblastic invasion would already have started and almost nearing completion. And latest before 20 weeks of gestation, you need to start aspirin. With regard to low molecular weight heparin, you need to start it if you know that the patient is APLA positive.
So that was the answer for Dr. Kirtana. If a patient presents at 33 weeks with severe pre-eclampsia, I think, with imminent signs, and a Bishop score is favorable, should we give vaginal delivery or cesarean since it's preterm? See, this looks like 33 weeks, almost close to 34 weeks. If you find that the Bishop score is favorable enough that she will deliver within the next few hours, there is nothing wrong in giving vaginal delivery, because she's not an extreme preterm. She's 33 weeks. But then please remember, you have to know how severe is her blood pressure, how bad is her maternal condition and her fetal condition, and you have to individualize. There is no contraindication for a vaginal delivery, but you have to individualize this case before you think of a vaginal delivery. In uncontrolled severe preeclampsia, should we have to go to termination immediately or wait for steroid action for 48 hours in 30 weeks of gestation?
In this case of severe preeclampsia, you need to know how well her blood sugar, her blood pressure is controlled with your IV antihypertensives. We need to know how her labs are. If they are all coming under control, then you could wait for 48 hours for your steroids to act. But if the blood pressure continues to remain uncontrolled, her lab parameters show derangement, then definitely you will not even wait for those 48 hours and you will like to terminate the pregnancy.
What's the role of umbilical artery Doppler in a case with previous preeclampsia done at regular intervals during an antenatal period?
The role is of uterine artery Doppler. The uterine artery Doppler will show a high PI in the first trimester screening. So the first trimester screening includes a lot of things which will predict preeclampsia. One is your history taking, then comes your mean arterial pressure, then you will have your PAPE, which will tell you a low PAPE is again a marker, and then you have your uterine artery PI, and some people also include placental growth factor. With all these growth factors, you have a built-in computer in the fetal FMMU unit, which you can feed and you can get your prediction for preeclampsia. So umbilical artery Doppler will come later on. It will not come in the initial prediction.
Umbilical artery is more relevant when you have a fetal growth restriction, and uterine artery more in prediction.
And if you get an abnormal umbilical artery Doppler at as early as 16 weeks or 18 weeks, I think it denotes bad prognosis.
There's a question by Akasha says that ACOG says 3 to 4 weekly ultrasound with AFI monitoring, and that is uterine Doppler, ultrasound with uterine Doppler. So it depends on the previous history, how frequently you want to be doing, because persistent notching, it's only for prediction. Beyond a particular period, uterine Doppler may not be too relevant in prediction. And what is the possible etiology of a second trimester HELLP around 19 to 20 weeks? Very unusual.
It generally occurs in the late second trimester or the third trimester. Generally getting at 19 to 20 weeks is very, very early. The only thing I can say is that rather than looking at etiology, we can go in for termination.
It's very unlikely to find at such an early period, but of course, like we said, it's for termination. I think we are done with all the questions. How much Maxel should be given for prophylaxis? It is at the same dose. I think we have answered all the questions. Are there any further questions? I think we are done. If there are no further questions, we are sharp 4:59 now. Is Usha there from Fourrts? Do we call it a day and then we wind up?
Yes, madam. Thank you, madam. Thank you to both the doctors for giving a wonderful lecture. And it is more like a practical thing, and hope many doctors have actively participated. Thank you so much, Usha ma'am and Jaya ma'am. Thank you, madam. We'll close this session.
Thank you.